right, hello everyone. Thank you for joining us today for CHEST's webinar, Shared Decision Making in Chronic Obstructive Pulmonary Disease Treatment, New Patient Tool. My name is Melissa Bustamante, your moderator for the next hour and the Patient Education Specialist at CHEST. Some quick housekeeping rules. This webinar is being recorded. All participants are muted. If you have any questions during or after the webinar, please feel free to submit those in the Q&A box located in the lower right-hand corner. We will have time at the end to answer questions. A reminder, this presentation was developed by the American College of Chest Physicians with support from Viatris and Theravance Biopharma. This webinar does not provide any CME. Today's speaker is Dr. Edward J. Bujold, MD. Currently, he is the senior scientist with the American Academy of Family Practices National Research Network and member of the North American Primary Care Research Group, where he is involved with many ongoing projects. So without further ado, please help me welcome Dr. Bujold.
So, thank you, Melissa, for the introduction. The objectives of today's discussion are to discuss the principles of patient-centered care and team approaches to healthcare, and also talk about discussions surrounding shared decision-making, highlighting the importance of talking about patients' desired lifestyles, and develop consistent and trusting relationships. In addition, we're going to review a tool that the CHEST Foundation has developed, which I think will be very helpful for patients. I am a family physician. I've been in the same location for 36 years, and I am in a solo practice with a nurse practitioner. And that practice is in the foothills of the Appalachian Mountains in a little town called Granite Falls. I've been practicing pretty much complete family practice except for obstetrics now, and I still work in a hospital, and 90% of my time is spent in clinical medicine. So I was asked to give a look at how a family practice physician or a primary care physician would approach somebody with COPD. And the first thing I want to talk about is goal-oriented medical care. And I'm going to give a little shout out to Dr. James Mould. He's a good friend of mine, and he's the person that really has spearheaded this concept of goal-oriented medical care. He's written 2 books, one for patients and one for physicians. This book that you see here, Goal-Oriented Medical Care, Helping Patients Achieve Their Personal Health Goals, is the book that was written for patients. And he and I have talked about this a lot over the years. Once we got inundated with electronic health records, and it seemed like CPT codes and ICD-9 codes and E&M management codes and filling gaps in care sort of overtook us. And it's almost like the patient has become secondary to what we have to do in the electronic health record to get paid, for one thing. But it's been very frustrating for all of us, I think. And the electronic health record has actually kind of been a barrier in regards to communicating with patients. To me, it's been so much of a barrier that I don't actually bring a computer into our examining rooms at all. Anyway, the 4 principles of goal-oriented health are avoiding a premature death and disability, participating in meaningful life activities, becoming more capable and adaptable in an ever rapidly changing world, and then experiencing a good death. And I'll give you examples of how these can be incorporated into patient care as we move forward. The other thing that I've been very involved in for several years is patient-centeredness and team-based approaches to care. When I first got into practice, the physician was basically everything, and he did everything. And as we've evolved in medicine, it became apparent with the complexity of medicine that the physician in and of himself or herself couldn't really do everything. And so we started to add team members to our clinics. And at various times in my 36 years in Granite Falls, we have had access to mental health providers, PharmDs, patient nurse care managers, physical therapists, dietitians, and then we can bring in others depending on the need, palliative care, hospice, etc. And in this setting, my role now has almost become more like a CEO. And it's much easier for me to practice medicine by sharing the burden with other people. And I'll give you a couple examples of that too. So our goals as physicians managing patients with COPD are many. Probably the first is to keep people out of the emergency room. And the second would be decreasing the revolving door of hospital admissions and readmissions. And I'll have to say, using this team-based approach to medicine and setting patient goals, over several years, I've been able to decrease our hospital admissions by over 80% and our ER visits by over 80%, not just for COPD patients, but for a lot of other patients. Other goals that, you always talk to patients about are increasing exercise capacity, increasing patient autonomy to take control of their disease. And that's where I think goal-oriented care really comes into play. And then patient education, and that entails many things, use of inhalers, various medicines patients might be on, how those medicines may affect other disease states that the patient may have, use of bedside spirometry, and use of pulse oximeters. Use of pulse oximeters has been just of tremendous value, particularly as we've been inundated with the COVID pandemic. So in goal-oriented healthcare, certainly the obvious goal is you want patients to survive. And when you look at COPD patients, most patients, when they do die of a respiratory infection. So we talk a lot about having them avoid environmental pollutants, staying away from people with infections, particularly small children, making sure their immunizations are up to date, getting them to practice good hand washing techniques, good dental hygiene, and getting them involved in good and adequate nutrition. Quality of life strategies, a lot of that centers around oxygen delivery options and pulmonary rehab. I don't know about the people that are listening to this webinar, but I've had probably the most difficult time trying to get people into pulmonary rehab. And growth and development, learning about COPD can be done through COPD support groups that usually are found in most areas of the country. And last but not least, at some time, we all need to have a discussion about death and dying and how the patients want this to play out. I find those are really very easy conversations to have, and I think most patients would like their healthcare providers to talk about it. But as I always tell patients, we want your death to be the death that you want, and we want you to be in control of that process. So, what are the two most important treatment modalities in COPD care, but also the most difficult to achieve? And in my practice, they're getting people to stop smoking and convincing patients to enroll in pulmonary rehab. I've lived for 36 years in North Carolina, which is one of the tobacco capitals of the world. And I have patients in my practice. This may be hard to believe, but some of them started smoking when they were 3 and 4 years old. And in my experience, anybody that starts young, and a lot of 10, 12, 14-year-olds years ago, it's very difficult to get them to stop. I would think in patients like that, nicotine is almost, if not more addicting than heroin. So I wanted to talk about a couple of cases where I've applied patient-centeredness and team-based approach to cares and goal-oriented patient care. The first patient, and both of these were patients of mine, which I've taken care of for a long time, but first patient was a 75-year-old, developed community-acquired pneumonia, presented to the emergency room in acute respiratory distress, and shortly thereafter was intubated and mechanically ventilated. And he spent 2 weeks on a ventilator, and during that time he had 2 strokes. During the evaluation of his strokes, he was noted to have an ulcerated plaque in a 90% obstructed carotid artery. This was actually resected during this hospitalization. He had a carotid endarterectomy, and he fortunately was able to be extubated, and by the time he was ready for discharge, we were able to discharge him to home. So I followed him up within a week, and his chronic problems were 4 outside of the stroke that he had just had, and those were COPD, nicotine addiction, chronic alcoholism, and depression. And I had specific goals that I wanted him to address. And the first couple of times I had him back in the office, I realized these were my goals, they weren't his goals. And so this is where the goal-oriented approach to medicine comes in. I sort of turned the tables a little bit, and I said, Tom, what are your short-term goals here? And he said, I want to get out of this damn wheelchair. I would like to be able to drive and take my wife to a restaurant, and I'd like to be able to walk into the restaurant and have a nice meal with my wife. And when you ask questions in that way, it's really surprising sometimes what your answers are. And so I was then able to have a discussion based on what his goals were that helped me with my goals. And I said, Tom, first of all, we need to get you to stop smoking, and you've got to stop drinking. And this depression is something that, you've never dealt with, and I'd like to move forward with that. And I find frequently people with COPD have depression, and a lot of times they self-medicate, which is true of most mental health disorders. In this case, he self-medicated with nicotine and alcohol. So we brought the team together. I have a mental health professional in my office, And he agreed to see the mental health professional who dealt with his depression, but also with his nicotine addiction and his alcoholism. We got him on Chantix and got him on an antidepressant. And I find it's very difficult to deal with patients' medical problems until you can deal with their mental health issues and their chronic addictions. We also convinced him that it would be good for him to enroll in pulmonary rehab. And then when his depression started to lift, he was much more interested in doing that. And within about 6 months, he was able to get through all the goals that he talked to me about originally. And I really probably couldn't have gotten him to do any of this unless I looked at it from his goals as opposed to my goals. The second patient was also quite interesting. He was a 70-year-old, had smoked since he was 10, severe COPD. He was also an insulin-dependent diabetic. He had coronary artery disease and had had 3 or 4 stents placed. And he was also depressed. He had recently gotten married, and his wife was just extremely frustrated because he continued to smoke. And he didn't manage his diabetes very well. And that was increasing his depression, actually. There was a lot of marital discord. And over the last year, he had had 6 hospital admissions and he had had 10 ER visits. And I had taken care of him for a long time. And I never really had gotten him to buy into changing his behavior. And that started to change as I had had more and more conversations with Dr. Mold. Dr. Mold, by the way, is a geriatrician, retired now, lives in Chapel Hill, North Carolina. He worked at the University of Oklahoma for several years, and he's a member of the National Academy of Medicine, and a wealth of information about all sorts of things in medicine. So anyway, I asked Jim what were his goals. I mean, you know, where do you see the rest of your life playing out? And he said, I don't want to be in a hospital. He said, I hate being in an emergency room. You know, I go to the emergency room and I'm there for hours on end. And frequently I get admitted, and my life's just not been very much fun. So taking that goal, we again talked about, you know, one of the first things we need to do is deal with your depression and your nicotine addiction. And so we brought mental health people in again, did some counseling. We also brought his new wife in and did some marital counseling, and we started him on Chantix and an antidepressant. And actually he did quite well over about 6 months. We also got dietitian involved with the PharmD in regards to educating he and his wife about his insulin-dependent diabetes. And it was quite obvious that he had very little insight into his diabetes, what part diet had to play with that, what part insulin had to play with that. And in addition, once we got some buy-in with some of these other processes, we were able to get him to pulmonary rehab. And then in the following year, he had no hospital admissions and 1 visit to the emergency room. So those are just some examples. This is a little different approach to managing COPD. It's probably a bit different approach than a pulmonologist would use. And part of it for us is that COPD is just one of several problems that we end up having to deal with. And they all interact with one another. And there's such a big component of mental health to these diseases that it's hard to move forward until you address that problem first. So now I just want to introduce to you the COPD tool that the Chest Foundation has developed, and we're going to play a video here to start. It's about a 2-minute video, just to give you an idea what this is all about.
Welcome to Chest Learning. Let's check out one of our newest courses that's being developed right now. This course is being created to instruct patients on how to have difficult COPD conversations with their physicians. Everyone experiences chronic obstructive pulmonary disease, or COPD, differently, which is why talking to a doctor about a personalized management plan is crucial for coping with the disease. Yet, with a variety of treatments and delivery options available, it can be difficult to know how to start that conversation. That's where COPD shared decision-making comes in. In this adaptive scenario-based course, patients begin by selecting a friendly guide to help them evaluate their lifestyle. Their answers are then turned into personalized treatment recommendations, and they are encouraged to explore information about these treatments and other treatments that could be available. Through engaging interactions, patients build confidence about how they can manage their COPD and are prompted to select the treatment method and delivery options that they would like to discuss with their doctor. The ever-present guide helps highlight important considerations to help patients visualize a plan that will fit their lifestyle. The experience provided throughout this course will leave patients with the knowledge and confidence to talk to their doctor about a personalized management plan. This course will also give patients the option to email or print a transcript of their recommendations based on their selections. They can use this physical guide for their shared decision-making journey. At the end of this engaging course, patients will walk away prepared to play an active role in managing their COPD.
So you can access this tool by going to the Chest Foundation website. And if you look under lung health from A to Z and go under C on the right there, you'll notice there's a tab for COPD. When you click on that, and if you scroll down to the bottom of the page, you'll see the tool. And there are 4 main sections, as it was described in the video. There are lifestyle questions, disparity issues to deal with, treatment types, as far as what patients might be looking for in regards to inhalers and things, and then delivery devices. And then at the end, you can get a report, and patients will participate in shared decision making. And it's a very elegant little tool for patients that I think can help them. And I think that's about it. I'll certainly be around for a while to answer any questions that anybody has. And thank you very much for your time today.
Thank you, Ed. Thanks everyone for joining. And if you have any questions, please feel free to put them now on the Q&A box. If you have questions afterwards, you can also email us at the Chest webinar email.